But it's clear that early this disease will be detected, then more chances for survival in the future. So if we look at this figure, we spoke already what uh, benign diseases. This is the biggest part of gynecological pathology. But practically all these, the malignant tumors developing on the basis or against the background of benign disease. If they look, for instance, cystic disease of the breast, without treatment, a lot of chances, it's in the first place in the in the pathology and gynecology. Without treatment, sooner or later, we can wait the development of malignant disease. Uterine fibroids, no, it's quite rare, I mean, malignization. Sometimes, yes, it can be in a sarcoma, but half of a woman in gynecological clinic and outpatient clinic suffering from uterine fibrosis. Endometriosis, yes, approximately up to 4% of the cases, we can see the transformation, the endometriosis into the adenocarcinoma. And ovarian tumors, 30%. Of course, we spoke already, what majority of them, this is a benign condition. This is a cyst, even follicular cysts. But sometimes we can see the hormone-producing tumors, malignant tumors, such as seminoma, dysgerminoma. If we look at the in general structure of incidence of malignancies in female, again we see what on the first place we see breast cancer, and also 4 and 5 places. This is corpus of uterus and cervical cancer, and cancer of ovaries. If we have a deal with any disease of mammary glands, fibrocystic disease, we have to keep in mind possibility, also the presence or development in the future, this condition to the breast cancer. Also cervix. Now we spoke already about huge amount of the women suffering from papillomavirus. And of course, if we doing the warned about possibility development of adenocarcinoma, cancer in situ, and ovaries, of course. If you look again at the amount of incidence, on the first place, again, breast cancer, uterus body cancer, cervical cancer, and ovarian cancer. Unfortunately, the figure showing the active detection by doctors this condition is maximum 15%. Maximum 15%, because just doctor cannot see it and do not remember about possibility. The problem with doctors in any specialty now, unfortunately, young doctors, they try to treat not disease, but the symptoms only. If we will switch on our brain, our clinical thinking, we can prevent up to 30% of the woman just to detect it in time. For instance, last year I had a patient. In the end of all, she had bilateral ovarian cancer, and I prepared her for operation, for hospitalization. But it was May. And many doctors refused from the planned operation this period because vacations soon will be, etc., etc. And in clinic, where she was directed, she received an answer, please come to us in September. She came in September, and already the metastasis was detected. This is a cost. This is a cost of, I can say what this is, mistake of doctors. But nevertheless, despite what immediately to make an operation and remove both ovaries and uterus, because she was approximately 50 years old, it's not necessary to perform their organ to keep their organs. She died, I think. I don't know exactly, but I think what she's already died. Because metastasis in the lungs, in the liver, do not give the chances for survival. So if we look again at the statistic, we see what it's directly related with the age of woman. When older woman is, then more chances for development of the cancer. If you look at incidence in 25 years and 55 years, it's more than even more than 3 times higher. An average maximum indicator is menopause and early postmenopausal period. I told you what now the life expectancy in women increased. Now, if you look at an average, it's more than 74 years. 25 years ago, this period was shorter. It was 65 years. And keeping in mind, this is indicator of increasing of frequency of cancer related with age. We have this. This is oncovigilance or oncoalertness. This is now, it's very modern trend. It was maybe in the last 5 years in every scientific international conference, 100%, what you can hear the report about oncovigilance or oncoalertness, what's necessary to educate the doctors, patients, etc., etc. But problem is without, yes, maybe it's a modern, but it's necessary. Without this, without oncoalertness, there are very typical problems. What patient, month after month, visiting the different specialties of the doctors, different. And each of them, okay, it's not mine, go to gastroenterologist, or you have a blood in urine, go to urologist, maybe in the end of form someone sent to gynecologist, because oncologists at all, yes, there is a branch of medicine, oncology. But into this specialty, there are a lot of direction, oncologist, gynecologist, oncologist, mammologist, neuro specialists. And very often, we can suspect the possibility of oncology even on a stage of collecting of anamnesis. If we're really collecting the anamnesis, not just ask, what's the day of your last menstruation? Is it painful or not? No. Ask about family anamnesis. And very often, because oncology directly related with the heritage. This is the main mistakes. And first of all, incomplete examination. Very often, in the international recommendations and clinical protocols describing the work of gynecologists, on an initial survey have to include the examination of mammary glands for each patient. But I know even in a daily practice, maybe half of the doctors do it. All the rest just sit on a gynecological chair, take the smears, make the vaginal investigation, and that's all. But on the first place, the breast cancer. I cannot, by naked eye, to detect breast cancer. Only by palpation I can suspect, and then to carry out the spatial examination, mammography, ultrasound. Yes, clinical errors can be, but in a 5 times less than just incomplete laziness of doctor, incomplete examination. Yes, sometimes it's even morphologic error could be, but doctors becomes too lazy and bad educated. So if we look at this is gynecological group of patients with this pathology, what we can keep in mind. And first of all, very often this is women with a low educational level. And one of the reasons of very late appeal to the doctor. Majority or half of them, they're lonely. They're lonely. And again, they do not come to the gynecologist till the end, maybe. Genetic predisposition of cancer. For us, more interesting from the mother side, of course. Very often, if we speak about the breast cancer or ovarian cancer, practically in 1/3 of the cases, we can meet the mention about cancer in the past, in the family. Increased body weight in women leads to the development of hyperestrogenemia. Hyperestrogenemia leads to the development of endometriosis, uterine fibrosis, and cystic fibrous disease of the mammary glands, which later can be transformed into the cancer. Of course, most for us, most dangerous from our point of view, this is hormone-dependent cancer. And this is hormone-dependent cancer. They practically always developing against the background of endocrine disorders, hyperestrogenemia on the first place. Age, yes, age. After 30 years old, we have already suspect in every woman after 30 years possibility development of malignant tumors. Heredity also, but necessary to collect anamnesis for it. And of course, bad environmental factors, ecology, etc., etc. But this is on the last place. First of all, collecting anamnesis, we have to exclude hormonal-dependent cancer. When we can start to suspect malignant tumor? First of all, after a routine examination, such as ultrasound, any volume formation, small pelvis. In the first place, I have to think, well, this is cancer. And better, I will exclude cancer. Then I put the diagnosis 100%, this is retention cyst. No, it's enough. We have now instruments, tools. We can use ultrasound, mammography, even magnetic resonance investigation. Also, in any violation of the integrity of cervix, or vulva is quite rare cancer, but nevertheless, cervix, we have to exclude the malignant process. Also, we have a lot of tools. We have a blood tests. We can make the cancer markers. We can also to perform the colposcopy, extended colposcopy. Also, increased abdominal volume in a short period. Also, Of course, maybe it's a progressive obesity, but I think, as we spoke already, more often it can be water, liquid in abdominal cavity as a result of cancer of ovaries. Maybe it's a giant tumor. I show you the photographs. Tumor more than 25 kilograms, tumor of uterus. And therefore also we have to suspect any violation of stool and urination. Unfortunately, with these symptoms, more often patients go to their gastroenterologist, surgeon, proctologist, or urologist. But if we work with coordination with them, for instance, in one clinic, always can consult such patients. Any non-physiological discharges. Yes, maybe it's just a symptom of erosion of the cervix, but on the basis of erosion, later can developing papillomaviral infection, and in the end of all, we can see the cancer. Macrohematuria. Yes, maybe it's a papilloma located in a urine bladder, but we can think that it can be cancer of ovaries with the growth into the urine bladder. Chronic anemia, yes, sure, it's always in any malignant process. Or even on the basis of anamnesis, the patient which have more than 3 risk factors. So, for instance, obesity, hormone-dependent disease, endometriosis, and heredity. It's already 3 risk factor, and we have to make the study of this patient more detailed. All these women in a perimenopause with a cycle violation, especially after menopause. It was 1 year menopause and without any drugs starts their blood discharging again. Practically all this is a symptom of cancer. Any abnormal secretion in postmenopausal women, practically always related with the malignant tumor. So as you see, we have a lot of tools in oncogynecologists. This is a cancer of ovaries. This is one case, and bilateral cancer of ovaries. It can be visible, of course, maybe only with palpation through the vaginal arch. It's difficult to establish such diagnosis. But we have, anyway, a lot of tools, instrumental investigation. Always we have to palpate the male-located lymph nodes. This is, again, it's an obligated procedure by the breast examination. Not only palpate the tissue of the mammary gland, but male-located regional lymph nodes. Colposcopy, vulvoscopy. Now, practically in every office of gynecologists, there are colposcopes. In obstetrics, of course, it does not use, but in gynecologists, it's very widely. Per week, I don't know, maybe daily, I do 1 colposcopy. Cytological study, it's obligation, it's mandatory procedure in each visit, especially first visit of patient to the doctor. We already can detect the stage 1 of cancer. As I told, tomography, irrigoscopy, if we suspect, for instance, the growth of a metastasizing cancer into the rectum or into urine bladder. X-ray of the chest, before any operation, we have to perform this study. Remember what with the ovarian cancer, we have metastatic, it's a left lung. And now a lot of radioscopy and radioisotope method of investigation. Bone function studies, nevertheless, densitometry. We can do it, especially in postmenopausal women. Tumor markers in the blood tests, SR125, SR135. It's a markers of ovarian cancer and breast cancer. And laparoscopy, diagnostic, like here, this is diagnostical laparoscopy. Of course, after this, in this case, laparoscopy is not enough uh, to perform the radical operation and necessary to continue operation with laparotomy, because necessary, in this case, necessary the bilateral ovariotomy with appendages, with tubes, removal of uterus, and removal of regional lymphatic nodes. It's impossible to carry out through the laparoscopy only. So, I mean, this is main indicator to include the patients, suspected patients, into their surveillance groups. Well, first of all, age. Always when we see after 35 years, it's already, we have to keep idea if possible, it's a risk group, this age. Anamnesis. I saw, for instance, in Germany, before visiting the gynecologist, I mean in a clinic, but not in an office, the nurse give the questionnaire to the patients and waiting the doctors. Patient fulfill it. And doctors do not lose a lot of time asking, only if unclear situation. And also keep in mind, this is pre-cancer of border conditions, such as endometriosis, uterine fibrosis, hyperplasia, any hyperplasia of endometrium. It can be polyp, any kind of fibrosis, cystic breast disease. Because first place in malignancy, this is breast cancer. Even obesity, as I told, or hormonal infertility, it's already cancer group, high risk factor. And also, it's not our obligation, but desirable to explain the patient. If patient noticed any formation on her breasts, and normally desirable to recommend them daily in the morning palpation, self-palpation of the breast, neck, and groin area. They are located the lymph nodes. And if she feels something necessary, run to the doctor. Also, changing the shape and size of the breasts. First of all, the color of skin, integrity of the skin, no swelling. Of course, to check asymmetry of the breasts for woman for herself is quite difficult because she see each every day in a mirror. But if she suspects it, better to visit doctors. So, as I told, we spoke in a previous semester. You saw that slide. There is hyperproliferative diseases in gynecology. And this is fibroid endometriosis mastopathia and endometrial hyperplasia. All of them related with the exceeded level of estrogen. Molecular biological features are the same. And practically, you see the target group, this is target organs for the future development of cancer. Therefore, the patients with this kind of disease had to be included into the high-risk group in oncology. So let's running through different diseases. First of all, fibrocystic disease. We spoke already that this is disease name have a lot of synonyms. Fibrocystic mastopathy, uh, benign breast diseases, etc., etc. But the last recommendation of World Health Organization, we have fibrocystic disease of breast. This is total name. Every cancer always has pre-cancer. Cancer cannot develop on the empty surface. Have to be pre-cancer. And the fibrocystic disease, it's a perfect pre-cancer conditions. If you look at the what cancer itself, it's only 5% of patient with this this is a fibrocystic disease, only 5%, but the highest rate of mortality. So mastopathy is one of the synonyms. But mastopathy, it's not one disease, it's a group of diseases with different abnormalities and structure of mammary glands, especially glandular part, because in majority of the cases, the malignant tumor develops from the glandular tissue, not fatty or connective. So, therefore, each woman visiting gynecologist has to be inspected from this point of view, presence or absence of fibrocystic diseases. Also, this is international recommendation to visit gynecologist for healthy women 1 time per year to investigate the smear from cervix and vagina, to make an ultrasound. Healthy women up to 30 years old, we can recommend 1 time per year visit, and only ultrasound, like a tool of investigation. Because mammography is more, of course, more effective, more informative, but has a radiation. Other 31 years, we recommend mammography. Now, of course, we can do mammography in younger women, but we need indication for this and serious reason. Without any suspicion, after 31 years, once per year, we recommend ultrasound, and better is mammography. Remind you what this is fibrocystic breast disease. We can divide on 2 forms. Diffuse form, this is more often what we can see. And nodal form, this is more dangerous from point of view of cancer development. Nodal form, fibroadenomatosis, fibroadenoma, or even solitary cyst. In this case, for differential diagnosis, we need a punction, because the ultrasound and X-ray examination is not enough. We have also to use the function. And inspection and palpation, this is a first step. Breasts and original metastasis zone. Also ultrasound. Ultrasound, this is again, after palpation, we already can to establish diagnosis fibrocystic disease, diffuse form, for instance, or nodal form. After it, next step, we send this woman depending from her age, to ultrasound or mammography. If we have some unpleasant findings, such as nodule form, we have to make a breast puncture. And it's mandatory to investigate the blood test for oncomarkers, SR153. Recommend you to remember the number of the Soviet Army, 153. There it's specific for breast cancer. 125, this is specific for ovarian cancer. Again, if we take the border disease, such as fibroadenoma, this is nodal form of fibrocystic breast disease, then older the women in the presence of fibroadenoma, then more chances to receive a cancer, especially near 30 years old, up to 20% of the patients. And I can say that this is the age for women when she more often visits gynecology. So we spoke about the external inspection. First of all, looking at the skin. Some color spots, it's very suspicious. Deepening, especially deepening in the skin, because this is a cancer, and very often it's located under the skin and closely related with the skin. They're connected with the skin. Changing the texture, like an orange color. Contour, changing of nipples. No, of course, any kind of liquid from the nipple. I don't speak about the blood, of course. If it's blood, does it mean that already the blood vessels destroyed? But especially premenopausal, menopausal women sometimes have a complaint on not blood, serosal liquid, which they notice when pressing the nipple or the breast at all. Therefore, what we have to do, again, take a glass and take a smear of this for oncocytology. Very informative. I told what there is ultrasound, there is X-ray examination. In this case, in mammology, mammography is more informative and describe very clear symptoms of benign and malignant process. This is mastopathy, ordinary fibrosed cystic mastopathy. Here we can see, this is lines, dark lines. This is connective tissue, excessive growth of connective tissue. Here we see cysts. We can see the clear border between the cyst cavity and surrounding tissues, one or another one, and this is cancer. No, first of all, no clear border. This is first symptom. And some inclusions inside. And it's a very typical location for the breast cancer. Upper quadrant of the mammary gland. If we use only ultrasound, for us it will be difficult to distinguish them. So also here we see the cysts, fibrosed cystic disease. We see one cyst, two cysts, and connective tissue. This is light lines. Here, this is a cancer. This is a cancer. Formation, volume formation, can be there palpable, without any clear borders. Of course, to confirm diagnosis, we have to, in both of the cases, to make a puncture for morphocytology investigation. But already this is a very clear symptom of cancer. This is breast puncture under local anesthesia. As I told, mammography recommend after 35 years old. Before, if I do not suspect such conditions, I recommend ultrasound. This is typical mammograph from United States, General Electric. Woman sits in front of it, put her breasts on this table, and make a photograph. Well, this is tools for punction. And after punction, we can do cytological investigation, histological investigation, just simple light optic or immunohistochemical study. And 100% it can be confirmed the cancer. Also, computer tomography. The problem is that not every clinic has a computer tomography, even in Moscow. But nevertheless, it's clear to see. You see, we can see the ducts. We can see the some suspected formations. And we can, line after line, we can check over mammary gland. Also with very informative, very harmful and expensive method, like a mammoscintigraphy with radioisotope of technetium. In this case, this is technetium, radioisotope, collecting in the cancer tissue. And like in this case, we can see bilateral cancer and plus metastasis into the thyroid gland. Maybe this is thyroid gland, maybe it's an area of parasternal lymph node. But this is cancer. But of course, it's only in some cases we can recommend such study. So next large group, this is the cervical cancer. We already spoke about this when we had a class dedicated for cervical diseases. There are some stages, as you know, in cancer, in any cancer. There is a lot of classification, 10M classification for oncologists. For other specialties, more recommended stage 1, 2, 3, 4, up to 4. And of course, every location of cancer, not only in gynecology, have his own terminology. But clinically, what for us interesting, I remind you, stage 1 of cervical cancer, stage 1A, practically we can detect it only by the cytological study. It's practically invisible, nothing, even if we use colposcopy. Stage 1B, we already see the changes on the surface of cervix and diameter less than 4 centimeters. It's already clinically visible, and we have to start the differential diagnosis. What is it? Is it papilloma? Is it condyloma? Is it ectropion? Maybe erosion? In this stage 1B, this is clinically manifested study. Then the process still growing, tumor becomes more than 4 centimeters, and in the end of all, it's fulfill all the space of cervical canal. This is adenocarcinoma. Stage 2 characteristic the transmission of the process on the walls of vagina. Stage 3, it's already growing of the tumor into the neolocated organs. It can be rectum or it can be urine bladder. Well, stage 4 is already metastatic stages. It's total lesions of the uterus, bladder, and rectum. No, in last stage is metastatic one. This is the metastasis in the left lung and the liver. It's very characteristically for cervical cancer. In the end of the class, we will have the tests and therefore try to remember what I told. For first of all, differential diagnosis and primary diagnostics, widely we use not only the cytological study of the smear from the cervical canal, but very informative, this is a colposcopy, simple or extended. This is photo show you the procedure. This is like a microscope. We use different impregnator of the tissue, usually is acid, 2-3% acid, and a solution of Lugol, iodinate, in order to painting the tissue. After the impregnation of acid, we see so-named white epithelium. This is pathological epithelium, because normal tissue made just a little bit more pale, but pathological changes becomes very clear detected. Here I can tell you what this is, a pre-cancer condition. This is sin 2 or sin 3 even. It demands already quite serious operation. This is papilloma, which growing on the basis of previously existed erosion of the cervix. Of course, it's not a present also, but it's a worse because this is pre-cancer, and this is only background diseases. Of course, we have to detect what types of the viruses are here. There are high oncogenic risk and low oncogenic risk. Therefore, here it's clear, even on a first visit, we can already start to suspect any cancer abnormalities. This is without any coloring cervix. We see something atypical. Color of epithelium, we see quite unusual, like a scar area. After we impregnation with the acid, here clear, visible, white epithelium, pathologic epithelium. After we painting with Lugol solutions, normal tissue, they becomes brown because it's iodinate. Pathological changes, we're not able to change the color. This is confirmation. Next step, what we have to do to take the biopsy from this suspected area, and after it, decided the question about future tactics. But I think that this is at least sin 2. And here also necessary, the surgery is necessary. There is a lot of method. Of this situation, ectropion. I remind you what ectropion, this is a result of the rupture of the cervix during the process of labor. And if doctor did not reconstruct the integrity of cervix, we will receive ectropion. This is practically normal epithelium of cervical canal. It had to be inside, but then it's after Usually we have a quite rough scars here. And this is ectropion, but difficult to detect from the first point of view. And therefore also we use the extended colposcopy. And this is, I remind you, this is ectropion, this is a best A port for landing of papillomaviral infection. It's best, because papillomaviral infection, invasion, starts with the epithelium, first of all. Of course, this is a flat epithelium, but this is cylindrical. This is a lot of glands, and of course, for virus, it's more convenient to perforate or penetrate into this kind of epithelium than in a flat one. This is different kind of neoplasia. This is without painting. It's difficult to say what is it, and looks no so terrible. After painting, we see practically all the surface covered with the white epithelium. And after we use solution Lugol, we clearly see the area of lesions without clear borders. And this is very symptomatically for cancer. This is, again, without the biopsy and colposcopy, we cannot say what is it. Is it condyloma? Or this is cancer already. And therefore, it's easy to detect. It's clear what in naked eye, even visible, this picture. But after it, we use painting with the acid and Lugol and take the biopsy from the most suspicious areas. This is cervical condyloma. Also, this is condyloma. But it's necessary, again, to take a biopsy. Indication for colposcopy, not to every woman which visiting me, for instance, outpatient clinic, I start to carry out colposcopy. No, only if I have some suspicions. First of all, I introduce the mirrors and look at the cervix and the vagina without any colposcope. But if I see some spots unclear for me, some changes, I doing this colposcopy. All the procedure takes, I don't know, maybe 10 minutes, no more. It's a painless. Very often also on a wall in front of patient, there is a screen, and women can see the picture translated from colposcope. And we can explain her what is it, what we want to do. But then is necessary, first of all, erosion, yes. Erosion, endometriosis of cervix, of course. Any vascular dilatation of the mucous layer. We have to understand what is it. Any warts of the vagina, it can be papilloma, it can be condyloma, anyway. And of course, always before any surgical manipulation, this is a mandatory procedure. We have to, for instance, to put in a case history to print what there is no changes or detected some changes. Simple, it's without painting of the tissues, only using the microscope. Extended, we using acid and a solution of Lugol. Chromocolposcopy, this kind of colposcopy using in diagnostic of some tumors or pathology of vagina. Usually we can take the methylene blue or any fluorescence reagents. We painting the vagina and after it looking at it. In the case of cancer, if we or several pre-cancer changes, if we use the methylene blue, This lesion will have a blue color, easy detected and clear visible. So let's do 10 minutes break, 8 minutes break. In 11 we will continue. Are you agree?
Okay, Professor.
Mhm. The things which I tried to told you during the last some semesters, I tried to inform you about practical aspects. Think about scientific aspects you can read by yourself. Let's do the small clinical exercises. It's a real situation. On Friday evening, my former student called me by phone and told me a very sad story. Now he's a cardiologist working in Moscow, and his wife is a therapist also. She was pregnant, 5 weeks of the pregnancy, and decided to carry out the medical abortion, drug abortion, non-instrumental, on a standard scheme, mifepristone plus misoprostol. After a couple of the days, it was normal reaction, menstrual-like reaction, repeat 5 weeks of pregnancy. Uh, any discharges stopped from the vagina. And his wife started to feel some painful sense in the bottom of the abdomen. And they came to the gynecologist. Gynecologists told, oh, okay, this is incomplete abortion and necessary to repeat the procedure. Again, mifepristone and misoprostol, mifepristone and misoprostol. Plus, they performed the ultrasound investigation, and was conclusion what uterus is enlarged and fulfilled with anorganic substances, pieces, and the line border between endometrium and neometrium is clear. It means what there is no fetal egg. I mean, abortion was normal. And he called me to ask, is it necessary to repeat the procedure? Asking for what? What you will recommend? Who can tell me what your tactic in this case? Hmm? Diagnosis is hematometra. I mean, blood in a cavity of uterus. What we have to do? Dear friends, you without 5 minutes doctors already. What could you recommend to the patients? Of course, there is no reason to repeat procedure because abortion was successful. Mifepristone, I remind you, is lead to the acute of endometrium already, uterus fulfilled with this. Blood clots with endometrium. Misoprostol, this is prostaglandin, he leads to the strong contraction of the uterus. It's clear what it's useless to repeat the procedure. What you can recommend? Nobody knows the answer. But if you switch on your brain, strange, if you think what I will ask you on the exam about only the tickets or questions, no, I will give you such exercises. So what I recommend in this case, I told immediately go to the clinic, just in an ambulant condition. It's necessary to invite women to the gynecological chair, that the use of 2 GHz extenders just to come through the cervical, open the cervical canal, release this content of uterus, and intravenously 1 milliliter of oxytocin. That's all. Not necessary to repeat abortion, not necessary to make the instrumental scraping of uterus. We have always had the time to do it if necessary. Very easy, but doctor, first doctor recommend to repeat the procedure, absolutely useless. Second doctor recommend to administer dufaston. Dufaston, this is synthetic progesterone. Progesterone, as we remember, leads to the relaxation of endometrium. It cannot help to emptying the cavity of uterus. This is a level of ordinary doctors in Moscow. Therefore, try, if I speak some things, if you cannot understand something, ask me. Because it can be with your friends, can be with your relatives, your patients maybe even. All this manipulation will take, I don't know, 3 minutes maybe. Oh. Okay, let's continue. Do you see this and hear me?
Yes, Professor.
Uh-huh. So we spoke about the situation when we can suspect the malignancy, or maybe it's just the ordinary procedure. First of all, as I told, the first stage of cancer, we cannot see it at all by naked eye, and therefore we take the smears from cervical canal. We can do it with the spatula, plastic spatula, or with a brush. After it, we put it on a glass and send to laboratory. There's two ways. This is kind of traditional technique, like here. It can be liquid histology, like here. Single usage brush. After we take the smear, we just put the end of this brush into the special conservant liquid and send it to the laboratory. Especially we're speaking about analysis for types of viruses, papillomavirus. And this is technique. We insert it into the cervical canal, turn 5 times clockwise, and after it send it to laboratory. Very informative. This is first initial stage of screening. This is all the cancers. Here, without any impregnation, it's difficult to detect. Yes, it's an unusual color, but we needed to do a colposcopy. Here we see not already, I don't know what it is, maybe it's polyp, necrotic polyp, maybe it's a cancer. Here, even without the extended colposcopy, I see the very unusual epithelium with a high thickness of it. Here we see already blood and the extended blood vessels. This is, of course, the final diagnosis we can establish only after biopsy. But it's clear what this is, deep lesions of the tissues. This is distracting carcinoma of cervix. It's clear here what this is a cancer. As well here and here, these are different cases. Even here we see necrosis. This is cervical canal and necrosis around it with extent of vessels, surrounding vessels is also typical symptom. Very rare we can see the cervical carcinoma. because as I told, in majority of cases, this is related growing on the basis of glands, epithelial glands. Carcinoma developing from the connective tissue. This is very rare case. It's real carcinoma. But again, you see the sizes of uterus, you see the sizes of carcinoma. Nobody pay attention on these blood discharges, sizes, impossibility of sexual life. It's too late, Sunil. What the main mistakes? First of all, insufficient funding, especially in a small town, in the villages. Yes, this is objective. Insufficient qualification of the doctor. Now I told you the story, it shows us two different doctors in different places in one day make mistakes, so stupid mistakes. Lack of cancer alertness. Yes, doctor even cannot imagine, oh, this is cancer, really? And subjective, it's again related to the mistakes of the doctor. No takes the smears. Practically every first visit we obligated to take a smear and send woman for ultrasound investigation. It's obligation. Sometimes doctor is too lazy. Also lack of communications between the clinician and morphologist. Because not in every hospital exists a pathoanatomy department, that we have to send it somewhere in another clinic. And if it's lack of communication, answer can come maybe in a couple of months. It can be too late already. Of course, we spoke already, what now, again, another trend, it's organ preserving surgery and for cancer as well. But of course, we keep in mind and pay attention for age of woman. Is it reproductive age? Does she have a children? Of course, if this is just local on the cervix changes, we try to carry out the cervical conization to remove just tissue of the lesions. This is conization. In the future, she will be able to be pregnant and bear with pregnancy. Well, of course, the delivery will be with the help of cesarean section. Or if it, sometimes we have if we have a tumor in situ, this is necessary to make an amputation, vaginal part of the cervix. Anyway, it's again, we preserve the uterus and women are able to be pregnant in the future. Or, unfortunately, very often it's abdominal extended, radical extirpation of the cervix, and sometimes with the uterus as well. This is conization. Despite of its quite simple manipulation, it's necessary to do in a hospital only. We just make the remove part of cervix with the suspected area. This is high cervical amputation. Practically all the vaginal part of cervix is removed. Sometimes we have to remove all the uterus together with appendages, with various tubes, and local lymph nodes. No, this is radical operation. Even part of the vessels we have to remove. This is electrosurgery by radio wave equipment and a spatial conizator, different form. We can take a biopsy with help of this. This is coagulator. And we can take for biopsy or maybe for operation, organization. This is quite easy, technically, I mean, easy. This is electrode. This is for biopsy. We can do using different forms of electrodes. We can take the different shapes of biopsies, and after it to make a coagulation of blood vessels. This is coagulator. So this is an electrosurgical loop excision, lip loop. Again, practically it's painless and doing under the local anesthesia. It can be lidocaine, local impregnation. The color, it means what we, before it was performed extended colposcopy. This is solution of Lugol, it's not necrosis. In this case, it's very good, very clear, visible, the lesions area. Or more old method, this is knife conization. We can use the scalpel or electroscalpel like this. It's, of course, it's more traumatic. Now it's more often we use lip loop. This is conizator. This is kind of electron. We introduce it in a cervical canal and again turn around 36 degrees. You receive rhombus shape biopsy. This is after 2 months after operation. Because he was very suspicious place, and 2 months after operation we see the more or less normal scar and a healthy tissue around. Knife amputation, it's a severe, of course, and a very tough operation. What's the benefit of this modern method? Electrocoagulation, radio wave surgery, absence of zone of necrosis, minimal blood loss, because there is some regime when we, in the same time, we're doing the incision and plus coagulation simultaneously. Ultrasound amputation. What's the problem? You speak about the cancer, and of course, one of the indicators of efficacy of our treatment is this is 5-year survival rate. This is official indicator. On a stage 1B, remind you what this is, first stage clinically detected. It's visible. If we do everything in time on this stage, the surveillance is up to 90%. It's a very highly effective method. And plus, this is organ preserving method. Especially it's important for young women. This is a result. Practically always women have retained fertility. And half of them after this operation became pregnant. I'm not speaking about the in vitro fertilization, normal physiological pregnant. Of course, duration, it's high-risk group in pregnant women in this, because have complications. But this is complications related not with the gystosis, usually. It's mechanical, especially in the third trimester, because insufficiency of the cervix, cervical insufficiency. The weight of the fetus plus amniotic fluids 1 kilogram, and this is after such trauma, cervix is not able to keep such weight, and therefore, with women had to spend majority of their time during the pregnancy lying in a bed with the legs up. But anyway, half of them have possibility to become mother. So therefore, it's so important that primary prevention, suspicion of pre-cancer process. If I have some doubts, I'm gynecologist. I'm working in department of gynecological surgery. This is not my deal, oncogynecology. If I have some doubts, I send this patient to the consultation to the oncological outpatient clinic. It's no problem, but I have to do it. No one demands from me to perform the extended extirpation with the notes, etc., etc. But I had to send her to the narrow specialist in time. Look, perfect phrase. Yes, there is someone. It's a non-qualified doctor without any oncoalertness. Last one. This is tumors of ovaries. We had a class, special class. In majority of the cases, it develops on the basis of epithelium. More rare, this is ovarian stroma, and therefore, cancer of ovarian cancer, in the majority cases, this is epithelial tumors. There is some ways of it. More often, it's contact path of dissemination. It's very typical for ovarian cancer. For cancer of gastro, etc., etc. It's also, but in gynecology, the typical this is contact pathway. Also hematogenic and lymphogenic. This is contact pathway. And the dissemination comes from ovarian with tumors by the contact to the intestines, to again urine bladder, rectum, wall of abdominal cavity. In contact way it's enough. So here we can see adenocarcinoma of ovaries. We see the changes in the life, very tough in palpation. These ovarian, extended vessels. On the first look, it looks like some tumor-like formation. But no, this is ovarian cancer. Fortunately, in this way, women to lose everything, both for the ovaries and uterus with appendages. Because here already, you see the yellow color, this is already ascites. The ovarian cancer has all the typical symptoms. For instance, cervical cancer have to only initially abnormal vaginal bleeding or discharges from pelvic. Ovarian cancer have all of them. Pelvic pain could be urgent to urinate or constipation on the stages of dissemination already. Bloating of abdomen, pain in abdomen. All the rest, they have the smaller symptoms, and therefore ovarian cancer, it's more easy to make a correct diagnostics. I remind you the stages. Stage 1, the cancer is only in ovarian, 1 or 2, but it's located only in ovaries, stage 1. Will be questioned in the tests, in the computer tests as well. Stage 2, it's limited location to pelvis. Uterus tubes, yes. Peritoneal washes, appearance, ascites. Can be also involve the intestines. Stage 3, it's not only small pelvis, but limited in abdomen. This is already metastatic stage. Now, stage 4, it's a distant metastasis outside abdominal cavity, lungs, and liver. This is stage 1. Location located only on one ovarian or both ovaries. Anyway, it will be stage 1. Stage 2, it's already transition of ovaries to the body of uterus, to the tubes, but located in a small pelvis. Stage 3, located only in abdomen. No, stage 4, this is the end. And you look, stage 1, 5-year surveillance, is up to 90%. This is a price, it's life. This high percentage, this is a price for oncoalertness. In 4 studies, less than 20%, frankly, I never saw survival woman with the stage 4, because maybe my clinic is not oncological clinic, but it's unreal. And this is figures not in Russia, this is International Federation of Obstetrician Gynecologists. Also, oncologists have a TNM system. T, this is tumor, and node, and metastasis. Phase 2, there is tumor, but no involvement of nodes and no metastasis. We can meet any, there is a lot of classification, maybe like this, stage 1, stage B, 2B, maybe TNM system. They are correlating, directly correlation between each other. So, again, the algorithm of examination practically the same. Like for ordinary patient in gynecology, collecting anamnesis, complaints, especially we pay attention to the discharges from vagina, increased in circumstance the abdomen, pain, bloating, this is a general condition. This is changes in the shape of abdomen. Increasing this shape is more characteristical for patients with ovarian tumors. Ultrasound also we have to do. If we suspect something by bimanual study, I found some formation, volume formation in low abdomen, I can carry out rectovaginal study. Because it can be not only cancer, it can be endometriosis. You remember what on the 3rd stage of endometriosis, there is penetration of rectum, and which have blood during the constipation. Ultrasound and Doppler as well, because remind you, ultrasound Doppler mapping show us the blood supply of suspected formation. Usually, it's difference between the cysts and cancer, because cysts have no blood supply at all. But cancer always have a rich blood supply. Also, it's quite rare, but nevertheless, we can do it puncture through the arch to take the liquid ascites from the abdominal cavity for cytological examination. Computer tomography. Oncomarkers also. If we spoke about breast cancer, it's Solitary 135, here 125. This is 2 kinds of oncomarkers necessary to be studied. And practically always recommended the scraping, diagnostic scraping. This is for cancer of ovaries. This question will be 100%. Remind you what can be hyperdiagnostic because endometriosis also can be detected with the same marker. And therefore, if we suspect the cancer, this is 125. This is mandatory. This is a cancer of body of uterus in our clinic. Weighs more than 20 kilograms. And here we not only cancer of uterus, we have the uterine fibroids as well present. Question, first of all, question to the patients. What the hell you wear inside you, such heavy tumors, and did not visit the doctor? I'm sure she never visited the doctor because it's impossible not detect this one. I remember such case I saw when I working in Middle Asia. The relatives brings to me women. I don't remember her age. It was approximately maybe 60 years old. He was thin. Her skin was covered with herpes, and she cannot speak Russian. Therefore, the main complaint it was she's ill. Okay, I put her on a gynecological chair and tried to insert my fingers into vagina. It was successful less. Useless, absolutely. I cannot do it because all the vagina was covered and was fulfilled with a stone-like consistent tumor, approximately the same like this. Of course, these women die very soon because it was too late. We see what we have a lot of different methods of investigation. But all I want you to remember, just exclude. You are not oncologist, but you can exclude oncology. And after it's in a quiet and calm situation, start to treat your disease. Mind you, this is a very rare situation. This is the endometrial cyst, endometrioma in the same time, and this is uterine fibroids. It was so unclear case. Nobody can establish diagnosis. From one point of view, from one hand we have endometriosis, quite large cyst, but what is it? There is endometrioid cyst cannot locate it on the surface of uterus. It can be heterotopy only, but not such size. And only after operation, it was clear what an extremely rare combination, endometrial cysts plus uterine fibroids. Remind you that both of these formations have the same base, hyperestrogenemia. So ultrasound, as I told you, is extremely informative for us. If we suspect the malignant tumor, first of all, organ, ovary in this case, will be increased in size with a regular shape. And very often, cancer looks like cauliflower. It's very typical. This is tumor without clear border. There are non-homogenic content in. This is ovarian, and this is cancer inside. This is ovarian cancer. From the first point of view, we can make a visual mistake. Well, this is endometrial cysts. But no, we see what the shape is irregular and improper. And we have many nodes, cancer nodes. And we see, first of all, rich blood supply and extended arteries and veins. We have practically no ovaries at all. Everything fulfilled with the small and large cysts. Maybe this is just little bit piece of ovaries. Also, this is already metastatic process. This is stage 3 because this is amentum located and sometimes covered the ovaries. This is contact way of dissemination. In a large amentum, and maybe even in we see intestines. This is formation with unclear borders, with many cysts inside. Of course, we can do another method. In this case, always before to be sure this is ovarian cancer, we have to perform the magnetic resonance investigation, CARTing, with contrast. In this case, it will be, this is Doppler CARTing. As I told, if we compare, this is cysts and very poor blood supply, and this is a cancer. Doppler CARTing show us the degree of blood supplyment. And here, of course, no doubt, so this is cancer. It's necessary a quite large surgery. Here, too, in other cases. Sometimes it looks like a multi-chambered cyst. But no, we see even blood supply in a septum. This is cancer. Even in a septum, it's also very typical for cancer. Computer tomography imaging also can help us. Layer by layer, we can see this is cancer because it's related already with the wall of the uterus. There is dissemination on a wall, at an pelvic wall. It's additional method of diagnostics. Unfortunately, only 38% of the patients we can be diagnosed in time and have 1A stage cancer of ovarian, and 22 have 3 stage. That all the abdominal cavity involved in the process. And also, you see the direct correlation between stages of malignant tumors and 5 years surveillance. If it will be in time, if doctor suspected or women itself pay attention or something unusual discharges or unusual weakness, dizziness. In this case, she had the chances, not all of them, but 85% have a chances for survival. So this is the things which I want to tell you about oncoalertness. Repeat what it's not necessary for you to treat the ovarian cancer if you're a therapeutic or urologist, maybe, or proctologist. In this case, you have to suspect in time and send to specialists to exclude. And no one will blame you in it. If you have a doubt, better to send to the specialist. So let's running through the tests. Hello, wake up.
Epithelial,
Right, epithelial. Because trauma tumors, what is it? No, it's quite rare. In majority of cases, it's developing from the epithelial cells. What?
SA125.
Yes, yes. Well, this is. If we speak about the ovarian tumors, this is indicator. This is so
Increase in the abdomen size.
how it can be related with the hormonal activity. Increase abdominal size, maybe even as I show you the tumor of uterine body. Just switch on your brain.
Amenorrhea.
Yeah, hormonal active. It means what? Increase the amount of the production of hormones. Hormone regulates what? Pain, not. Dysuria, not. Only menstrual cycle. And therefore, amenorrhea, especially if it tumor producing the testosterone androgens. Immediately go to the for ultrasound investigation.
cytological,
Yes, yes. First, what we have check on a first visit. We take the smears from cervix and vagina. And if I receive an answer what there is atypical cells, in this case, I can to carry out morphological or in order to investigate immunohistochemical material, we have to do the scraping or take a biopsy. Not scraping, not biopsy. This is no screening method. This is diagnostical method. Yes, if I see the mention about presence of atypical cells, of course, I recommend ultrasound, etc., etc. Yes, I told you first changes, visible changes in this stage 1B. Stage 1A, it's on the level of cells. It's just damage to the cells. Yes, we can put this diagnosis again with the help of cytology. In this case, we can establish this diagnosis. But clinically pronounced changes the color of tissue, something papilloma, etc., etc. It's only 1B.
And then water secretion.
Not typical. It can be, why not? Especially if it's stage 2 or 3. Look, read again.
Abandoned watery secretions.
No,
Pain syndrome.
not typical. It's typical syndrome, pain. Syndrome during the intercoitus.
And the presence of spotting from the genital tract.
It's not typical.
Primary
This is first,
amenorrhea.
just a switch on the logic. Clinical symptom not typical for cervical cancer. It means cervical cancer destroying the tissue of cervix. Therefore, presence of spotting, blood spotting is characteristic. Pain syndrome, also dyspareunia, the name. Watery secretion can be in a stage 3. Only amenorrhea, because amenorrhea not related at all with the cervix, not anatomically, not pathogenetically. Amenorrhea, this is results of disturbance in the hormone regulation. Primary amenorrhea, especially primary, it means what this woman, this woman never had menstruation in her life. How it can be related with cancer? One A or one B?
One A.
Yes, one A. No more than 3 millimeter. It's practically invisible. It's only we can define it only under microscope. This is no clinical manifestation. Clinical manifestation will be 1B. Less than 3 millimeter. It's invisible. We can find it only with the cytological study and microscopy.
Maybe.
Huh?
Maybe.
Again, stage 1, located on the cervix. Stage 2, abdominal cavity. This is already germination into the bladder or into the rectum. This is practically metastasis. It's metastasis. It's not located on the organ because it's cervix. It's located already deep in the abdominal cavity. Any germination of the tumor to the no-located organs, this is practically metastasis. Not distant, very distant and nearby located. Keywords: perimenopausal period. Okay, this is a perimenopausal woman, yeah? And I have a cancer, ovarian cancer. Second stage, it means what is located in the pelvis, small pelvis. What we will do with this? For this patient, uterus does not need anymore at all. She's in a perimenopausal period. And also she had a cancer of ovaries. Second stage means bilateral. What we will do? But uterus also after 50 years old, it's a target organ for cancer, possible cancer. This is key word. It's perimenopausal period. In our organ protective strategy finished in perimenopausal period. Then women come out of reproductive age. It's not necessary to keep the uterus, to save the uterus for her. If it will be young women, no, not young in the reproductive age, no, maybe we do the bilateral adnexectomy to give possibility, theoretical possibility to use assisted reproductive technology in the future for pregnancy. In perimenopausal women, it's no pregnancy, we do not wait it. And therefore, we have to remove, especially at second stage, as much as possible. Even resection gastrocolic omentum. I show you the photograph. BMI is body mass index. We spoke what obesity is a risk factor for cancer. This is not gynecological question. You can receive this question on any examination. B, of course, 2026. If everything, this is obesity, we can establish diagnosis of obesity if it's indicator 30 and more. If it in this 26, 30, this is overweight. It's not obesity, but overweight. This is risk factor. If I see premenopausal woman with a fibrocystic disease, with maybe symptoms of endometriosis and with real obesity, it's no problem to calculate. We take the body weight in kilograms and divide it on a double length in meters. This is in the telephone calculator using. But this is evaluation of risk factors. I spoke. Very often, doctor does not do it. But if you will be work as an endocrinologist, for instance, or cardiologist, etc., you will do it practically. Have to do it practically every day. So this is. Wait a second. I want to do the cheese. So tomorrow for you will be self-preparation. It's clear for me what's the topics. It's quite difficult and large, but it's your last semester. When we finished this course, it means what you are. Yes.
Lectures for previous semester, for the 10th semester in April that we took with you?
Why you not ask me in a Friday to do it?
I had them, but now I have problems with the link and they won't open, so I cannot use them. Can you send them again for the previous semester?
Now, when you will send to me confirmation letter,
Yes.
make a mark, please send me. Just tell me what lecture you want, because you are not single group in my schedule. I also have now a 5 course, and therefore just little bit some mixing in my head.
Okay.
So tomorrow you will free day from gynecology, and in a Wednesday we will speak. Will be last topic: anomalies of the development of the genitals and genital prolapses. This is, I think, from my point of view, it's one of the easiest topic in this semester because it's quite rare. First of all, yeah, I'm here.
I got disconnected just now when you were taking the attendance.
You are disconnecting.
I got disconnected just now when you were taking a screenshot of the attendants who appeared in class today.
Oh, this is second screenshot. First screenshot I did after our break. Never mind. So see you after tomorrow. Have a good luck, and I wait only 1 hour. Your attendance later. Later, I have to stop new class.
Professor,
So, yes,
so tomorrow we don't have a lesson, right?
no.
Okay.
We spoke everything. We discussed everything today. So goodbye.
Thank you, Professor.